Welcome to Surgeon's Log 2021, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, let's get ready for yet another exciting and entertaining episode of Surgeon's Log 2021. Welcome, everybody, to our anniversary episode of Surgeon's Log 2021. We started this endeavor, Dr. Wong and I, in May of 2020, so this is truly our anniversary episode. And for that, we have another global episode for you. It's going to be very exciting. We have a great lineup of speakers. Our presenting surgeon is Antonio Aversa de Souto, who is the chief of neurosurgery at the National Cancer Institute in Rio de Janeiro in Brazil. Our discussant, our special guest, who will finish the webinar, is Professor Luigi Maria Cavallo, who is from the lineage in Naples that everybody knows about, of course, especially in endoscopic neurosurgery. The revolution that has been part of neurosurgery has been in large part driven from the group from Naples, and Professor Cavallo was part of that, along with Dr. Capabianca and so on. So he is from the Università degli Studi di Napoli Federico II. To start off our discussion is Michael Catalino, who is a PGY6 resident, going to be chief at neurosurgery at University of North Carolina. So your patient is a 28-year-old man with a chief complaint of headaches. The associated symptoms are slowness of thought. For that, I believe that means cognitive decline, drowsiness, ptosis in the left eye, and a decreasing of the vision in the left eye. And by the way, the unfortunate problem is that the right eye is blind from retinoblastoma many years ago, previously treated with radiotherapy and chemotherapy. So again, headaches, cognitive decline, and left eye issues, the only remaining eye. There are no mutations in the RB1 gene with this retinoblastoma. On your examination of this 28-year-old man, Mike, he's alert, but mentally he's kind of slow. There is left-sided ptosis, and the vision in the left eye is declining, and there is constriction of the visual field that you can see on the right side of your screen. The right eye is basically not usable, sees only a little bit of motion, but from the history of retinoblastoma. So with that, and with that history, usually I just go on right to the slides, right to the images, but Mike, can you localize that for me?
Yeah, I mean, based on I think the blindness in the right eye at baseline makes it a little more challenging, but I think that the left eye visual field pattern doesn't fit the typical vision loss for a chiasmatic lesion. From what I could tell, the temporal field was intact. I mean, not intact, but there was like macula, and some of the temporal field was normal, but nasal field was completely out. So, I mean, I would localize that lesion probably to an anterior cranial fossa, left-sided, sphenoid lesion around the optic nerve. I mean, theoretically, it could be an intraparenchymal lesion in the occipital lobe. I think that it's more likely.
How does the cognitive slowing help you?
I think the frontal. I mean, it's probably frontal syndrome. So his executive function and so forth probably is affected, which I guess would localize more to the frontal lobe. So I'd say anterior cranial fossa, left side lesion.
You are of course correct. All right, so this is the MRI findings of the current problem. I'm going to let you digest this a little bit, and then go on to the next set. Remind the audience that the right eye is the one not usable from the retinoblastoma. The left eye is being affected now. And I'm going to stop there and ask you, what do you think this is, and what do you think is next?
So looking at the lesion on imaging, it looks likely a neoplastic lesion. I think that other differentials such as infection and vascular lesions are less likely. The lesions exerting mass effect, basically anterior cranial fossa, also midline, but then left-sided into the orbit. So I think that the differential includes anterior cranial fossa, sort of probably meningioma. It looks like it's hard to tell where it's originating from. So I think esthesioneuroblastoma is in the differential. I mean, nasopharyngeal carcinoma, probably less likely, but also in differential, just given that its involvement of the ethmoids. I'd probably want to see a CT scan to look for hyperostosis. It may help with the differential.
All right, so you're basically answering the next question too, right? So you said a CT scan. With all those things in the differential, I think there's something else that you may want to consider too after the CT scan.
I would probably get an angiogram just to look at the vascularity of this.
That never hurts. That never hurts. What about, would it make a difference as to what you do for this if you are sure it's anesthesia, or you're sure it's a snuck, if you're sure it's whatever it is?
It looks amenable to a endoscopic biopsy just to obtain a diagnosis. Yeah.
Okay. All right. So I always like to ask this question. So Mike, as a senior trainee, can you tell the junior guys, what are your eyes looking at when you look at these pictures? What are you focused on, and why?
So first thing, I'm looking at the mass effect on the brain, the contrast enhancement, any sort of skull base attachments, and lateralization, or whether it's purely a midline lesion, because that would help my decision on how to approach this.
Okay, so the attachment of the skull base, where it invades, how lateral it goes, how medial it is restricted, all play into eventual selection of the approach. Am I taking words out of your mouth? That's about what.
Yeah, that's right.
All right, so what is your goal of treatment for this 28-year-old with only one functioning eye?
The primary goal is preservation of left eye vision. And in that context, basically reduction of mass effect to, I think it's maximal safe resection. Okay. With that in mind, I would favor preservation of vision overly aggressive. I would really highly prioritize preservation of left eye vision.
All right, so that's very important, and I think I would agree with your sequence. I think the decompression of left optic nerve, or the preservation of left eye, is number one. You achieve your number one goal first, and then the second goal may be maximal safe resection for potential, decompression, obviously decompression of the brain, and potential cure if possible. All right, I like those goals. It's next set of questions have to do with the famous arrows of the Surgeon's Log 2021. What arrow do you like, and why?
So I like, two things I'm thinking of. First thing is, this is a big tumor and I think it requires big surgery. So I like the red arrow, sort of a frontal basal approach. A caveat to that is, I would say that I'd want to see how the tumor is invading the canal, because I don't think it's unreasonable to start with a endoscopic, optic nerve decompression.
Oh, I like that. Two-stager. Okay. I don't have a CT for you, but I completely agree. I mean, it would be very useful to see how much this tumor gets into that canal. especially with your primary goal being the number one goal being to decompress that left optic nerve. Okay, uh, so you're not just liking the red arrow though, you like the orange arrow as well.
Yeah, I think, yeah, I'm tempted. What I don't love about resecting the whole tumor from the orange arrow is that basically, I mean, I feel like I would see a lot of tumor um, before and there's a lot of lateral extent. So I would have to, number one, get into the orbit probably, which, early on in order to decompress. And there would be a lot of tumor in my way. And so I would see the optic nerve, later on if I started right from resection. And I think that a frontal basal approach would just allow, I would be able to get a better circumferential exposure to achieve both goals, uh, you know, uh, both goals of resection and protection of the optic nerve.
But let's assume that the CT scan shows that the tumor is completely invaded into the left optic canal. Would you do the orange arrow as in stage one?
Yes, I would. I wouldn't take the resection all the way. I think I would still stage it.
All right. So
I don't know if I would try to get the whole thing with just endoscopic approach.
when you say that you were doing stage two from the top, are you taking the orbits one side, both sides, or at all? In other words, would you do a transbasal or just a bifrontal?
I would do a transbasal, but only take the left. I mean, I think his right eye. I think I would.
Okay, so
he's young. Yeah, I would do a transbasal.
This is very interesting because Dr. Al-Mefti just submitted a video to ONS with this. He calls it the 1.5 or whatever. It's basically a transbasal, but only involving one orbit. And this is the perfect case for it. Right? You certainly don't need the right. I completely agree with you. Would you embolize this before your stage one or stage two?
I would get an angiogram, and if it was highly vascular, I would embolize. I think that my concern for embolization, depending on what the angiogram shows, embolization could result in, ischemia of the optic nerve, depending on what or not the nerve, but it could theoretically have, complications related to vision loss in the left eye, depending on what the pattern is. So I would be, unless it was clearly beneficial, like highly vascular, I would probably avoid embolization. But if it was going to be very vascular and I could improve operative visualization with an embolization and blood control, I would.
So it's a very difficult question to answer because we don't know what it is, right? So let's say the biopsy comes back, it's something, it might give you a clue as to the embolization, whether it's yay or nay. Assuming that this is a meningioma, the spus applies from the ethmoidals. I'm not so sure that embolization is achievable or safe for all the reasons you already brought up. Plus, you're doing the stage one of the orange arrow going through the EEA, and actually, Danny Perverdello has a concept that he likes, which is to do that to not only do some of the work, but also to completely dry up the tumor with killing the blood supply, so that when he does do stage two, it becomes a very dry tumor and a much smaller operation because of that. All right, so let's summarize for the audience here. You're doing two-stage operation, endoscopic endonasal for decompression of the left optic canal, and followed by a transbasal, well, half transbasal, 1.5 transbasal to get the tumor from the top. How far apart are you separating the two stages?
I would plan on doing the endoscopic. I would probably do it one day and then do the next day. I think okay. that would be my plan.
Same admission, but not the same day.
Yeah, I'd be tempted to do it all the same day. Honestly, if the endoscopic, if it was not, if I could get blood, control the blood supply, the tumor was not highly vascular, I could, decompress the optic nerve in, by noon or something. And if it wasn't ended up being a favorable tumor, consider doing it all in one day just to avoid overnight intubation and prolonged stay for him. But I would plan on doing it 2 days.
Outstanding, Mike. I would I applaud that plan. I like that plan. In fact, I have nothing to add on that plan. So wonderful. We're going to turn the podium now to Antonio, and he's going to tell us what he did, and let's see whether he agrees or not with our thoughts. Antonio, go ahead.
Thank you, Professor John, for the nice invitation. It's an old case I have done 8 years ago. It was a very challenging case because it was a single scene patient in the left eye. He was losing the vision. So, but we thought at the beginning that it was aggressive meningioma because of the past history of radiotherapy 20 years ago in the treatment of retinoblastoma. So this is for reviewing the anatomy. Would you, from the work of Professor Horton, this is for explaining our philosophy in treating those patients. This is the relevant anatomy. You can remember the canthal ligaments also for the approach that we have used and the invasion of the left orbit and the kind of approach that we prefer to do in those patients in this pathology of this region. Would you, next slide, please. So this is when you do the approach in the subcranial way, I think is the best name for this approach. We can have a very good exposure of the nasal cavity, the paranasal sinus, the orbits, and the whole anterior fossa. Next, please. So this is the kind of angle of attack and vision that you have when you do this kind of approach that we preferred to do in this case. Next, please. So you can reach the sphenoid sinus also in the whole anterior fossa. Next, please. So what was the goal of the treatment in this particular case? As Dr. Catalino mentioned, the preservation of the vision was the main goal, and also preservation of mental and neurological condition, avoiding neurological deterioration for intracranial hypertension. And he was also, we were very concerned about the CSF leak also in this kind of great resection because the risk of not be able to achieve a very good reconstruction and closure of the dura. Next, please. So those are the options. Basically, Professor Cavallo is going to show his tremendous experience with the endoscope for those kinds of pathology also. The bifrontal craniotomy, I'm not using this anymore in the last 20 years because we have also afraid of losing the big flaps in this kind of pathology. And then I think it's completely unnecessary to do those large craniotomies. Perional approach is an option, but is very restricted in the exposure of the nasal cavity. So we prefer to do subcranial approach. Next, please. So this is our philosophy. We can achieve a very good viewing from the nasal cavity to the nasal cavity from above, and you can also achieve also a very good inferior view to the whole anterior fossa in this kind of pathology. So we can cut it's a single osteotomy in the frontal sinus and nasal bone, and we can see how lower you can perform the osteotomy in the nasal bone, depending on the pathology. Next, please. So this is not actually the video of this particular case. It's only for demonstrating how we perform the subcranial approach. This is the bicoronal incision and deflecting the pericranial flap. This is detaching the supraorbital nerves. And then we are doing the osteotomy with the bone scalpel with ultrasonic bone scalpel for doing. It's very quick procedure, very simple. I think all of the neurosurgeons would do this much more frequently than people are using today. So this is the single flap. Then we can perform the drilling of the posterior wall of the frontal sinus and an eggshelling, cutting the orbital roof, taking the crista galli. So we have all the space necessary for approaching all the anterior fossa. So opening the dura in a very inferior incision, cutting the superior sagittal sinus. You can also use the endoscope for following the procedure from below, cutting the involved dura. This case was a nasal cancer. It was not a meningioma, but then we cut the folks, resect the dura, and then that's cutting all the infiltrated dura, and then we can perform, this is the big difference from the Indonesian approach, with the fascia, temporalis fascia, a very watertight closure of the whole defect of the dura in the arterial fossa, and then we can have a very low index, a very low rate of CSF leaks. So this is how we perform this kind of approach with a single small craniotomy in the frontal sinus and the nasal bone. Next, please. Next, please, next. So this is the real case. This is with the microscope. You see how infiltrated was the posterior wall of the frontal sinus. The crista galli was infiltrated, mainly in the left side. So we first we take the tumor, the extradural tumor in the nasal cavity tumor. Then we perform the opening of the dura. We take the infiltrated dura, all the infiltrated dura. So cutting, after coagulating the ethmoidal arteries, the tumor was completely devascularized. This is one of the advantages of this approach, using the CUSA for decompression, internal decompression. So we feel like we are doing a convexity meningioma when you are doing olfactory groove meningioma in this way. That's the beauty, the big difference. So we do not touch the frontal lobes. So we are now dissecting from the frontal lobes without any kind of retraction, you see. So in a resection, in a piecemeal, and then taking the lamina papyracea of the medial wall of the left orbit, and then we can close with the temporal fascia in a watertight fashion, and then using the pericranial graft also for reinforcing the reconstruction. Next, please. So we could have a total resection of the tumor, was a meningioma grade 1. We know that those meningiomas, even if they are grade 1, they are much more aggressive. They radiation-induced meningiomas. The Ki67 was not so high, 2%, and progesterone receptor was negative. We could achieve a complete resection with resolution of proptosis and a complete rhinological recovery, and the vision was intact after that. And unfortunately, the right eye was almost lost just before. And we could not have any kind of CSF leaks in the post-op. Next, please. So this is the post-op 1 year later. And we do not send the patient for radiotherapy. It was not necessary in our opinion, because he was previously radiated also, and was a complete resection. Next, please. So that's the beauty. You see the T2 images, you do not touch the frontal lobe. So you don't have any kind of injury of retraction in the frontal lobes. And the patient really is different with this kind of approach. Prevedelo has already showed this the same with the endoscope. Professor Cavallo has also probably the same experience. We do not touch when you come from below with the subcranial or with endonasal, and do not retract the frontal lobes, and the patient is much better in the post-op. Next, please. And the patient, this is the sagittal also. Next, please. And he remained stable. It's almost 8 years of post-op without any kind of recurrence, and he is doing very well. So I have, if I have time, I'm going to show very quickly a little bit about the approach. It's a very inferior angle of view, no frontal lobe retraction, a wide exposure as you see, with the at beginning coagulation of the ethmoidal arteries, with the possibility of olfactory preservation in a few cases when it's not lost. And that's a big difference. The reconstruction is much better than we can achieve compared with the endonasal approaches, with excellent cosmetic result, with no facial scars, no facial incisions. And we can also, well, endonasal assistance is very welcome for this procedure also. Next, please. So this is only a few examples. I started this experience with the malignant tumors. Aesthesia neuro is perfect for this kind of approach. Next, please. This is post-op. Next, please. Another big aesthesia neuro. Next, please, with the huge infiltration of the anterior fossa. This is how we perform the osteotomy. Next, please. Is a very short video in aesthesia neuro. This coagulating of the ethmoidal arteries, anterior ethmoidal, cutting the olfactory groove. And then we are going to dissect and then resect the extradural and intranasal portion of the tumor. It was a vegetating tumor in the nasal cavity, so it was relatively simple to resect. It was resected almost in one block. In this case, sometimes they infiltrate the turbinates. It's not so easy, but in this case, it was a huge lesion, but it was not so difficult to resect the intranasal cavity. It was assisted by the nasal endoscope also. So we took the portion of the nasal cavity first, then we can create the space for resecting the intracranial portion from below. This is the assistance from the endoscope. And then we cut the infiltration of the nasal septum. You can see the turbinates there. And then we go to the anterior fossa. We do this for the meningiomas with infiltration. Also, this is ligation of the sagittal sinus, cutting the falx. And then we create space for pushing the tumor downwardly with this kind of approach. It looks is a small craniotomy, but it's enough for resecting this tumor because we have a vision from below. So we can, it was infiltrating the frontal lobes. We do not have sometimes a good arachnoid plane, but it was large for doing a resection in a single piece. We had to cut the tumor and then decompression, but we could achieve a total resection with this approach without any kind, you see, no retraction in the frontal lobes. So at the end, we can have the all dura of the anterior fossa, cutting all the infiltrated dura. Those are the optic nerves there with the supracellular system. This is the cavity of the frontal lobe because of the tumor. And then we can have a cut in the dura of the planus sphenoidale, cutting the infiltrated bone in the planus sphenoidale and the sphenoid, and take the whole tumor out in the single approach. It's a very interesting approach in our opinion, this kind of subcranial approach for both the nasal cavity and the anterior fossa. So this is the last piece of the tumor. And then that's the vision, nice vision we have at the end of the procedure. Next, please. And this is the closure with the temporal fascia. Next, please. Next, 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 please. Okay, this is another examples of meningiomas that we start to do. And then next, another meningiomas. We can have where's the sinus with the transillumination with the endoscope that is in the operated field. Next, please. And then we can perform the osteotomy with the reciprocating saw. And then with the chisels also is a very quick procedure. I think it's much easier to do than the bifrontal craniotomies. And then we can fix even with the nylon sutures if you don't have the plates in the poor countries or so. Next, please. So this is the view in the post-op without retraction of the frontal lobes. And this is our experience. I'm going to go quickly this. We had only 2 CSF leaks in 58 patients with the subcranial approach with 2 mortalities. Telecanthus you can have if you do not fix the medial canthal ligament. This is difficult sometimes when you have destruction in the malignant cases. Next, please. So this is the problem Professor Cavallo is going to discuss, but the CSF leak in the endoscope is still very high, and the problem of anosmia. This is the review of Schwartz a few years ago. Next, please. The problem of CSF leak also in this meta-analysis is still high, 25% in the endoscope procedures for olfactory groove meningioma. So for finishing, this is comparing the both approaches. The endoscope and the subcranial, we have very good advantages. So these drawbacks and the advantages of the craniotomy and the endoscope. And I think we should use the subcranial because you can have both the advantages of a craniotomy and an endoscope approach with a very low rate of CSF leak. So thank you for the attention. Let's discuss later.
All right, that's an amazing presentation, Antonio. I really enjoyed it. Let's see how I can get out of this. How do I unshare? Where am I unsharing? Mike, you might have to help me here. I'm having a little bit of trouble unsharing his. Missing the bar. Okay, there we go. I'm going to stop sharing. Okay, everybody's back live looking at people. There's a lot to unpack there, and it is my job to kind of dissect that discussion for the audience who may be young trainees in addition to seasoned people. One of the most important concepts in that discussion is the bifrontal versus retraction discussion. There's a school of thought that says even though a midline tumor like this, if you want to perform a transcranial operation, you may want to consider a unilateral approach because you only work under one frontal lobe. You don't end up damaging both frontal lobes. Okay, so even though it's intuitive to attack something like this bilaterally, there's some school of thought to attack it only unilaterally because of frontal lobe injury. Now, mind you, the traditional bifrontal attack for this giant tumor, I think very few people are actually doing subfrontal, bifrontal, subfrontal resection anymore. I think most people who would advocate a bifrontal approach would do bifrontal but interhemispheric, so that the retraction of the frontal lobe is not against gravity per se, but just side to side. Even with that, retracting both frontal lobes is a bad idea and a dangerous idea. I have personally had one encounter where post-operatively both frontal lobes started swelling, and that patient did not do well at all. So for the young trainees, when you're considering a bifrontal approach, really think about interhemispheric, subfrontal, and whether you should do that at all because of bifrontal injury. Maybe unilateral is better. Question for Antonio to start. What about a biopsy? You showed your esthesios and you show your meningiomas. Would a biopsy have helped here? Would a biopsy have changed anything? Did you do a biopsy for your case, 28-year-old?
For all the malignant cases, I think it's very important to do the biopsy because you can change it. It was a lymphoma, for example. But in this case, we are very confident it was a meningioma. It looked like very meningioma with the previous history of radiotherapy, so we didn't perform a biopsy.
Second question to you is, I personally really like this approach that you advocate. Got to try it at some point very soon. But for this particular case, the left eye is so important. and the left eye is the number one goal of the surgery, that subcranial approach doesn't let you decompress that optic nerve or optic canal really early. And in fact, is there trouble seeing all the way back? If the tumor is infiltrating the canal, that seems to be at the very, very deep side of the approach. Is that a problem, or was that a problem?
Actually, I'm sorry, I haven't sent the full images of the CT. In this particular case, we did not have infiltration of the optic canal. It was a huge infiltration of the orbit and compression of the optic nerve in the orbit. But I agree with you, it's a problem when you need the decompression of the medial aspect of the optic canal. But we can also achieve very well with the subcranial approach the medial aspect of the optic canal.
So you can go that far back.
You can also do the decompression in this way.
That bone scalpel is a new thing for me. I finally have it now. How long have you used it? And it looks to be an amazing application for this.
I've been using the last 5 years. A friend of mine that we are using to work give me told me that to use Dr. Nogueira for using this approach. In this approach, the bone scalpel is a very interesting equipment for performing the osteotomies in zygomatic osteotomy. So it's very quick, very precise, and very safe for doing this. The only problem is that produces a lot of heat, so we must irrigate all the time. But we don't have the problem of devascularization or healing the bone after that, no.
Okay. All right, I'm going to ask Dr. Wong his opinion about Antonio's case now. Dr. Wong was the lead author of the transbasal chapter in my book. So he actually wrote the chapter about this tumor in my cell-based surgery strategy book. So Michael, now that you've seen Antonio's presentation and approach, would you still do your transbasal for something like this?
I think this is a very interesting approach. I think that the CT scan would have been helpful in terms of understanding the infiltration of the optic canal. But given that there was no optic canal infiltration, I think this was a very slick approach with a very minimal neurological or frontal lobe disruption. So yeah. I think this was a really nice way of approaching this.
Yeah, I think you're thinking what I'm thinking. I can kind of see your gears turning that you got to try this someday, right? Very soon.
Right.
Michael Catalino, the other Michael. Now that you know from Antonio that there was no infiltration of the optic canal, would you still do your stage 1, stage 2?
Yeah, I think I would probably just stick with the 1.5 transbasal. I do have a question for Dr. Aversa. The reconstruction of the frontal sinuses and the nasal sort of portion of the frontal bone. So what's your strategy for cosmetic reconstruction for that area?
Actually, we cranialized all the frontal sinus. We took the whole mucosa for not have problems of mucositis in the future. And we closed the frontonasal duct with the muscle. And the cosmetic result is, when I started, was a concern, but it really a very nice osteotomy that we can put the bone back, and then it's perfect. We don't have problem. The main concern is about the canthal ligament. If you have to detach the canthal ligament, you must fix after that, because you can have the telecanthus if you do not do that. But for meningioma, it's not necessary to do as below as for detaching the canthal ligament. So, but the cosmetic result is very, very good.
Again, for the younger trainees, there's a historical point to be had here. The approach through the frontal sinus was also described by Dr. John Jane Sr. Many years ago. So if you might want to look up those papers, young trainees, because it gives you a historical foundation of how this has all evolved over the three or four last decades. Okay, now I think our special guest turn. Professor Cavallo, the floor is yours, and please tell us how you view this topic.
Thank you, John. It's really a pleasure to be with you. And thanks again for your invitation. I start to share my screen and to start with the presentation. Do you see the screen? Yes.
We can see your screen. Yeah.
Yeah. Okay. First of all, congratulations for the case of Dr. Antonio. It was really nice.
Luigi, we're only seeing your folder, your finder. We're not seeing a presentation.
You don't see my presentation? Okay, I will try to.
You have to click on the PowerPoint when it says share. You click on your PowerPoint, and then it shares the PowerPoint.
Now.
There you go. Now we're seeing your slide sorters. Yeah.
Now. It's okay.
Now it's good. We're looking at your olfactory groove OGM.
Okay, so in this slide you see what we have to respect when we remove an olfactory groove meningioma, and what we have seen in the case you have presented is exactly what is necessary. I like to show this paper, which comes from an Italian group, because I totally agree with the choice of the surgical approach. And I really like this transfrontal sinus approach, which, as you said, was originally described by John Jane Sr. And thanks to the modern equipment like the piezoelectric saw, the bone curette, we can really tailor this craniotomy without leaving any defect, so that the aesthetic result can be very good as well. And this was really a skull-based tumor, which required the skull-based approach. But in some other olfactory groove meningioma, there is not the involvement of the skull base. So there are also valid transcranial options like supraorbital or like the lateral supraorbital approach, which was nicely described and popularized by Ernest Niemi. So, like everywhere, we have to adapt the approach to the extension of the tumor. But I completely agree that in this case, the tumor was really invading the skull base. So the choice to go through the frontal sinus with the transbasal approach was perfect. Why I would not use the endonasal route? It was shown that during the surgery, the dura mater, the frontal dura mater was involved. You can see nicely here. And also, if you look on sagittal plane, this is not a favorable angle of view for the endoscope. So I would not use a purely endoscopic endonasal route for this case. But as you say, the endoscopic approach can be very useful during some of the step of the transbasal approach. For example, you can check with the endonasal route during the removal of the orbital component of the tumor, and also at the end, during the reconstruction step, you can check if the reconstruction is watertight. You can reinforce the reconstruction with some pedicle mucosal flap, and in this way, I would say the endoscopic route in this specific case can help the the tumor removal and the reconstruction step of the approach. The endonasal route, of course, cannot be used for all the cases, as I said, but because we have some anatomic limitation which prevent our approach to be used in all cases. What are the limitations? Mainly two. The first one is the frontal extension of the tumor, because we need this cortical cuff to remove the tumor through the endonasal route. And also the lateral extension of the tumor, which have not to go over the half of the orbit, because otherwise you have to do too much traction on the tumor and then on the brain. You cannot control properly your surgical instrument. So for us, these are the two main limitations. But of course, with proper indication, you can nicely remove this tumor. And as Dr. Antonio Souto said, you can respect the brain, because practically you don't touch the frontal lobes. And even if the tumor is calcified, you can nicely find the plane of the tumor with the brain. You can dissect and remove, and you see that at the end, practically you have not touched the brain at all. This is very important. Maybe you mentioned this paper from Danny Prevedello. Transbasal approaches, whatever it is, through the frontal sinus or through the endonasal route, really can preserve the frontal lobes. And this is very important, especially in those cases in which you have a lot of edema. If we look these algorithms that have been proposed recently by Ted Schwartz from New York, you see that at the end, the endoscopic endonasal route can be considered, but we have to use the proper criteria of selection. And mainly, this criteria of selection is based on the olfaction, if it's preserved or not, on the lateral extension of the tumor, on the cribriform plate invasion. So that if we consider this, you see if maybe if olfaction is preserved, the endonasal route is not good. If you have too much lateral extension as well, the endoscopic endonasal route is not good. But with the proper indication, you see the endonasal route can be considered. And also in this other paper from Semi Youssef, you see that if you have a complete loss of the olfaction, if you have an extension of the tumor through the anterior canal base, the endonasal route can be used. But as you said, the main problem of this approach, but not only for the olfactory groove meningioma, but for all the meningiomas and also for the other tumors treated through the endonasal route, the main problem was the CSF leak. But even if we look for the transcranial series, the rate is really not so low. So it's something that we have to consider when we go transbasally. But I think that the endoscopic approach can give some help. I mean, if you have a leakage after a transbasal approach, instead of going back transcranially and reopen everything, you can simply go endonasally and check the leaking point and see the defect through a minimal invasive route. And also when we look this high rate, we have to say that we pay the price of the learning curve, of course, at the beginning of the experience. So if we look the selection criteria today for olfactory groove meningioma, I would say that the best candidate for endonasal route are those patients who are already anosmic and those which have an extension inside the nasal cavity. This because with a single minimal invasive approach, you can remove small or medium size, but sometimes even quite large olfactory groove meningioma in a quite easy way at the end. But the olfactory groove meningioma, the transcribiform approach, is only one of the modules that we can use when we go through the endonasal route, because you see that the entire midline and skull base can be exposed passing through the nose. And in the next minutes, I just want to give you an overview of the current possibility of this endonasal route, that beside the olfactory groove, we can treat other meningioma. And you see, this is quite interesting because over here, we have collected not a lot of olfactory groove meningioma for the endonasal route, but more of course tuberculum cell meningioma, which of course is also controversial topic. These are the basic concept to remove tumors through the nose. These are the adjunctive tools which are useful. For cavernous sinus meningioma, you know, radiotherapy is for cases like this is the first choice. But when you have some esophageal component which compress the optic nerve of the chiasm, you can use this approach just to decompress the cavernous sinus, but also to decompress the optic nerve and the chiasm from this esophageal part of the tumor, which compress the nerve and the chiasm, respecting the superior epiphyseal artery, so that you can separate the tumor from the nerve before doing the radiotherapy. For tuberculum cell meningioma, this is the craniectomy we have to realize from the chiasm. This is the type of view we have after tumor removal. You see, you respect the nerve, the brain, the vessel, but it's very important to use also angled endoscope when you do this kind of surgery, because you need to see especially the vessel, especially the supracranoid portion of carotid artery. This is the tailored craniotomy you have to realize, and this is very important to extend as much as possible the bone removal over the lateral optocarotid recess. If you don't do that, the surgical corridor will be restricted. This is the same principle for convexity meningioma. You have to tailor properly the craniotomy over your meningioma. The same is for the endonasal route. To do that, you have to know very well the anatomy of the region, and the key point is to extend laterally the bone removal, to not limit the bone resection to the medial OCR, but to extend laterally, and you can do that. This is an anatomic study which shows that if you work above the optic nerve in the supraoptic area, you can expose widely the optic nerve until the entrance into the canalicular part, and you can even reach the carotid bifurcation. The principle of tumor removal are the same. You use transcranially, early devascularization, debarking, and you see that if you extend laterally your bone opening, you can control carotid and optic nerve on one side and also on the other. You see, if you resect this supraoptic area on the lesser sphenoid wing, you can really have also, it's also more easy to move the instrument and to dissect the neurovascular structures. And of course, when we look at the dimension of the tumor which are removed through the endonasal route, usually these are not so big. So usually a small or medium size, but which does not mean that are easy, because when the tumor do not displace the neurovascular structure, especially the optic nerve, sometimes the optic nerve do not tolerate so much this kind of traction. You see that's the post-op MRI, but sometimes you can manage also case not so small like this one, which was treated elsewhere transcranially with incomplete result, then was treated endonasally by us, and you see that at the end, this was the only sign of the previous surgery. This is another case we treated endonasally. You see with just this small remnant. So very important neurovascular conflict. You can see from the endonasal perspective. You see that especially when you have severe neurovascular conflict, the endonasal route gives the chance to remove the tumor and dissect the tumor from the nerve without any manipulation of the nerve. And this explains why the results on visual function are quite good. Even if you compare to transcranial series, since the beginning, this was highlighted, the result on visual function. We have tried to compare also with the transcranial series. This is a paper we made with the McDermott group. You see the very important to consider the extension of the tumor into the optic canal and also the carotid involvement. And of course, when you compare endonasal series with the transcranial series, you have a lot of limitation because, of course, the size of the tumor is much higher when you look at the transcranial series. But also, if you look around the world, there is an increasing number of papers considering the endonasal route for tuberculous cell meningioma. So this means that probably the results are not so bad. Even on this paper we made in the European skull-based section group, in the conclusion, of course, transcranial approach remain the gold standard, but if we look at the visual function, we have to say that the endonasal route has some benefit in regard. Another point to discuss is the optic gun elevation. You see that when the tumor grows into the inferomedial aspect of the optic canal, like I would say most of the meningioma, tuberculous cell meningioma do that, you can open the inferomedial aspect of the canal, but the problem is not the opening, it's not the resection. The problem of these cases in which you have the extension of the tumor inside the not only below the falciform ligament portion of the canal, but inside the canalicular part of the optic canal, the problem is the biology of the tumor. Because whatever is the approach you will use, you will never be radical, so that you have to consider also other options, not only the surgery. So vessel dissection is possible when you do not have a complete vessel encasement. We have honestly say this, because you see when you have a good arachnoid plate like this one, you can dissect the tumor, and you see you can do that without touching the nerve of the vessel. But the problem is when you have a case like this one, with the partial encasement of the vessel, you have to use 2-3 instruments. It's not easy. We made in this case, but I would not recommend to do this in other case. Of course, this is a limitation. Again, also for transcranial route, when you have encasement of perforating vessel, or when you do not have a good arachnoid plane around this teeny vessel, maybe it's a better choice to leave some remnant instead of trying to do dangerous maneuver. Spinal sinus configuration is another thing we have to consider, because there are good candidates for the endonasal route, like this one, when you have a wide-angle tuberculum like this one, or even like this one, very deep cell, not easy for a transcranial approach. But there are also bad configuration like this one. You see small sphenoid sinus. And in case like this one, maybe it's much better to do transcranially instead of doing endonasally like we made. And there are also contraindications for cases like this one, you see, with the wide attachment over the planum, like this one, no space for the endonasal route. I would not recommend. This case has been treated transcranially and is, of course, much easier and faster to do that. But with small attachment over the planum, of course, you can remove endonasally. So there are criteria of selection for the endonasal route for tuberculum and planum meningioma. And I would say that best candidates are small, medium size without any vessel encasement, and especially these with the deep cella are quite easier to be removed endonasally. Just few words for skull-based reconstruction, because it was considered a limitation for the nasal route. And this is the current technique we use. It's very easy, very fast, and also seems to be very effective. It's called the 3F. It's made by fat, flap, and flush mobilization of the patient. The fat, of course, has been used since the 70s in pituitary surgery, but what we do, and also this author at Lowe's, Dan Kelly, and Charlie Teo has used not only in pituitary, but even through the skull-based defect. This means in front of the neurovascular obstruction, we use the fat like a cork stopper. This means that you don't have to use any multi-layer gasket seal or sphenoid balloon reconstruction without the need of use any more lumbar drainage. Then we cover the fat with the flap, nasoseptal flap, and at the end, and this is also very important, you have to mobilize the patient as soon as possible from the bed. So we never use again supine position. Is the worst position you can use, because when you have supine position, you have high pressure of your skull-based defect. If you elevate the thorax of the patient, you will have a decrease of the pressure of the skull-based defect. So this is an example just on this tuberculum cell meningioma, just to show you. You see, we just plug a piece of fat across the skull-based defect. There is practically no risk of overpacking, because you see the transmitted pulsation of the skull-based defect. We don't use any solid material to close, and you can use this through the olfactory groove, through the planum, through the suprasellar space, through the clivus, and then you cover the skull-based defect with the nasoseptal flap, and that's all. Then you pack the sphenoid sinus with some surgical, and you see this is a day one post-op CT scan. You see that the fat is positioned across the skull-based defect, and this way you can really seal all the corner around the defect. And then you see on MRI, this is suppression fat sequences at 3 months, and after 1 year, most of the fat will be resorbed. This is the series of 3F technique we have used, and you see that include also patients with the third ventricular opening for craniopharyngioma or other disease, and the result seems to be very good. You see just one patient out 90 need revision surgery, and that was a dermoid cyst, which is, in our opinion, but not only in our opinion, a contraindication for the endonasal approach. Please do not operate dermoid cyst in the suprasellar space through the nose. And then 2 minor leakage, which were sealed with some fibrin glue injection through the sphenoid sinus without the need of reoperate the patient. So this technique seems to be very promising, and it causes a dramatic reduction of the rate of post-op CSF leak. Thank you for your attention, and I interrupt the...
Professor Cavallo, what a tour de force of a presentation that is. Thank you for doing that, and also your experience is really second to none on the EEA, and thank you for sharing your wisdom. As moderator, I always like to pull audience members that we may or may not expect to attend, and it happens that I noticed that Andre Grotenhuis is in the audience. I'd like to ask him of his opinion. Professor Grotenhuis, of course, is senior skull-based surgeon in Holland and editorial board member of the Acta Neurochirurgica, amongst many other titles, and so on. I think he's happily retired, as far as my intel tells me. I'm curious, Andre, how would you have approached Antonio's case, whether you think you would have gone 2-stage, 1-stage, endonasal, transcranial, transbasal? What are your thoughts?
Oh, well, thank you, Walter. It was more or less by chance that I heard of this.
Welcome and thank you for being here.
Yeah, no. Well, actually, I am in the waiting room to flying to Barcelona. It's now more or less possible again, still with having PCR tests and double vaccination and so on, but because we have an ENS board meeting tomorrow. No, but this is very interesting. I think all parts have been covered. First of all, I have to congratulate Antonio by how to deal with this case, simply because this is what we do as surgeons. You have a patient, you have the goal of what you want to do for that patient. This is a young patient, probably post-radiation, large meningioma. And then you plan this carefully, and then you execute that plan perfectly. Well, so this was well done. And I look back, and again, when I see how you can reconstruct, it's just by suturing. That is, as was skull-based surgery at its best. How would I have done it? Probably because of all the developments. I maybe only wanted to add to all what have been said, that there should be no fear of doing a one-stage combined endonasal approach and a craniotomy at the same time. When I discussed this, and I have presented that in the last 20 years several times, there was always this comment, oh, no, this is sterile and the nose is not sterile. But if we see what Luigi was doing through the nose, you open it widely. You are in the intracranial compartment already, and you have CSF coming out. So that's all. We didn't do this very often. I only have 17 cases, not more than that. But these were the complex ones that were really, especially with lateral extensions that you couldn't reach endonasally simply. Just to say that's not a thing. I think Dr. Catalino was saying that right. I would do it the same day, but if you say the same day, I consider you start endonasally at 8 o'clock and you finish that at 10, and then you bring him back at 2 p.m. in the afternoon and do the craniotomy. No, but, and then everything is closed. It is a big advantage to have it open at the same time, from the nose and from above, because that enormously helps the reconstruction. We could quickly, I show you just how this is set.
Oh my, you come prepared with slides.
No.
That is the best cameo ever.
I'd only want to show you, this is how close it is then. Somebody working through the nose and somebody is working the craniotomy. It's close. The nurse has a difficult task because we as surgeons, we just bring those instruments back and give it. She has to separate them. But that is, and I can tell you that it is much easier to do it this way.
What is that headset that's on the endonasal surgery?
Well, that is because he didn't like to watch. I can show you on this was one of my fellows from Egypt who he is looking to a monitor. Do you see that?
Okay.
And this colleague of mine, Eric, is preferred this head-mounted display.
Okay.
But that is because this is more than 20 years ago. But personally, the resolution of that head-mounted display was simply not good enough. So most of the others wanted to look. But you see this odd, this turned head. That's not always easy to do so. So the setup is not easy, but technically, and I stop.
So Andre, you would do it two upstairs, downstairs simultaneously. It's very interesting. This is no longer a coincidence.
Yeah, to say that it is not the danger of those 70 cases, we had never an infection, and also no single CSF leak, because like Antonio was doing, you have from above much more possibilities to reconstruct the skull base and to properly surgically close this. And then from below, when I close it from above, From below, I start to rinse from above, and from below they just can see if there is still fluid coming out. Then you pack it again. You do back and forth, and this is a big advantage. And don't be fearful of doing this at the same time. But it means you need two surgeons. It's like having a dance partner together. You have to know each other, you work together. This is not a one-person job.
I was about to say that this is no longer coincidence, because this is the third time I've noticed that the youngest panelist and the most senior panelist agree with each other where everybody else is talking about something else. This cannot possibly be a coincidence. This happened 3 times. Okay, back to Luigi for a second. So Luigi, you said that you probably for Antonio's case would not do EEA as a standalone. Would you do a upstairs downstairs? Would you do a transbasal? What would you do for Antonio's case?
Exactly like Antonio made, with the endoscopic endonasal control just during the some step of the resection and especially at the end for the reconstruction, because maybe you can have the chance to add some neciceptor flap over the skull base to support the reconstruction. But like Andre said, you can check for the watertight of the reconstruction. So I think it's a really a good advantage to use endonasal route.
So you would also do a simultaneous upstairs downstairs?
Yes.
So there you
go. Like it's possible to do for some anterior canal base malignancies, for esthesioneuroblastoma, for some complicated frontal sinus mucocele, for other anterior canal base disease.
Fascinating. Dr. Catalino, is Nelson Oisiku next to you? Or can hear? If he is, please join the party here. So I'm going to ask for concluding thoughts. If anybody has any ending thoughts to discuss. I think this has been a fascinating case. It brings up so many different concepts and ideas. I personally did not think about doing this upstairs downstairs simultaneous, so I'm very fascinated by you all thinking about that, and I think it's a great idea. I'm tremendously enamored by Antonio's subcranial approach. I have to find the right patient to do this and try this myself, especially since I have the bone scalpel to use too. I think it's a tremendous tool for this. Concluding thoughts, Professor Cavallo, Antonio, Michael.
I had a question for Dr. Grotenhuis. How do you position a patient for the combined approach, as you mentioned, in terms of the head position?
The head position, it depends on how your craniotomy is placed. So if you would do this with a subfrontal, maybe even bilateral subfrontal, it's median. And if it is more frontal-lateral or supraorbital, since that is maximum 30-degree turned, I have a head clamp that I can turn around while the patient is still fixed. That's a custom-made thing for me. Although Walter was saying rightly, at the age of 67 in the Netherlands, you are obliged to retire. But of course, I'm not stopping being active, but this is more or less no. This is this is not so easy. You can't do properly endonasal approach with, let's say, a 60-degree turned head, but that is not necessary in those cases. It was mentioned by Dr. Jane that unilateral approach of these large meningiomas is advocated. Because yet you only would damage the frontal lobe on one side. I am not fully agreeing with that, because if there is a bifrontal lesion, just dissecting it, even from one side, you can already have some damage on the contralateral lobe also, simply because the tumor has done that. And the way Professor Aversa was showing that is surgically the best way to deal with the frontal lobe, because you see what you're doing. But nevertheless, I think this is debulking. Slowly, this removing this and bringing it into the area. So this is a matter of planning, and usually with the part what we need, it's 20, maximum 30-degree turn of the head, and that it's still possible to comfortably doing an endonasal approach.
Luigi, concluding thoughts. Antonio, concluding thoughts. Any?
Please. No, I want just to say that I really appreciated the case of Antonio, really nice, but not only the case, because the entire series and his results are really good. So I think that this route seems to be really far more better than subfrontal or interhemispheric approach for anterior corneal base. I think it's really similar to the endonasal for the fact that you really respect and avoid any traction on the brain. It's a really skull-based approach. I like very much, and congratulations again.
Mm-hmm.
First, thank you, Professor Jim, for the invitation. Thank you, Professor Cavallo, for his huge experience to share with us, and Professor Grotenhuis. I just want to remark that I think this is a very important approach that most of the neurosurgeons even don't know, the subcranial approach. I think it has the same philosophy of my mentor, Professor Mefti, that came from laterally, taking the orbital rima. You can do from medially and do the same and have a very inferior angle of approach for the anterior fossa and also for the nasal cavity. And if you are thinking to go from above or from below, you can go from straight. I think it's better. So thank you so much.
So we are a little bit over time. So thank you for all the panelists, including Dr. Grotenhuis, for dropping in on us like this. I look forward to seeing all of you all in person next, because I think the world is now opening up and we can finally be together, hopefully soon.
Hopefully soon.
So join us next time in July for the next episode. And again, thank you for all the panelists. Thank you for the audience members. And we will see you soon in person, hopefully. Have a good day.